right, everybody. Welcome to another edition of the Better Care Podcast. Today, we're joined by Dr. DeAnn Bullock, who from Nashville General Hospital. She is the Chief Medical Officer and also continues to serve as the Emergency Department Medical Director, as well as Medical Director for the Sexual Assault Nurse Examiner Program. So needless to say, DeAnn, you've got your hands full. So we can't thank you enough for joining us on the podcast today.
Thank you both. Thank you for having me. I'm really excited to spend some time with you guys this afternoon.
Absolutely. Well, one, you got so much on your plate, and we're going to talk a little bit about that. But two, thank you so much. As we enter into the Thanksgiving week, we are thankful for all you do. And honestly, all the chief medical officers and medical directors out there, we can't give you all enough thanks for what you do to lead our hospital systems. And in most cases, like DeAnn, roll up your sleeves and continue to take care of patients. So thank you so much. So DeAnn, before we dive into some questions and kind of a discussion, tell us a little bit about how you got here and your background.
Yeah, sure. So I am a native Nashvilleian, so it was only kind of just wanted to be back home. I went to high school, undergrad, med school here, and left for training in Georgia. Always never really had CMO on the pathway, but I think if you look back and kind of look at all the things I've done throughout my career, it's always ended up in some form of leadership, some way or another. So it's just started along the way and kind of just added things on all through residency throughout my time in training, throughout worked for the military for a year as a civilian contractor, and then came back home. I've been at Nashville General the entire time. And I think part of how I got really into leadership around Nashville General is just also being a Nashville resident, knowing a lot of people, knowing how to get things done throughout this community and being that bridge. And so with that, wanted to really utilize that ability to kind of bring people together, but also bring them together in how we support the hospital, how we support the medical school. I am a Maharian by training in medical school. And so being back in the hospital that supports the academic mission of Meharry Medical College also, once again, put me in a role that was somewhat of a leadership role, guiding medical students and residents, served as quality director in the emergency department for a number of years before I became the emergency department medical director, probably about 13 years ago. And like everybody knows, the ED kind of everything rolls down to the ED, everything comes through the front door. And so by default, you are always there. It's a 24/7 job, it doesn't close. And so people need things done, they call on the ED. And so over the years, it's always been never say no, just take it, say yes, we'll figure it out when they get here. Doesn't matter what it is. And I've really just kind of supported my team in doing that. And I think that translated up to when the hospital was looking for a chief medical officer. I was always around and I was willing to take on the role. We had not had a full time chief medical officer in a very long time, had been in the role probably about a little less than a year. And then COVID hit, really just kind of jumped in the fire and kept it moving. So it's definitely been a number of years of challenge, of also gratification and being able to get a lot of really good things done, leading some really good teams to take care of the patients in Nashville.
Well, both Meharry and Nashville General play an absolutely vital role here in Nashville. And I want to make a comment on one of your statements about everything rolls down to the ED. Over 25 years ago, when I got into the hospital industry, I'll never forget someone said, "Hey, what are you doing tonight at midnight?" Because the single best thing you can learn about anything about hospitals, you have to be here in the middle of the night in the emergency department. And I thought, well, I didn't know any better. And I said, okay, I'll do whatever you think I need. But hands down, there's no better place to understand and learn about care, about hospitals, and about operations than witnessing what happens in the emergency department. So thank you for all your work there. And it's obvious how that's teed you up for success. So Real quick, post COVID, I think we've all talked about COVID enough. Post COVID, you've been leading Nashville General through some transformational programs and initiatives. Tell us a little bit about some of your top priorities and what y'all have been doing since then.
Sure. So there's been a number of different things that we've done. Obviously, like any other hospital system, we're in Nashville. There's a lot of competition. There's a lot of patients. There's workforce challenges, and that goes from nursing all the way to the providers. There's a lot of challenges that go into that. So you take our hospital, we are a city safety net hospital, and our goal is to take care of every Nashvilleian, no matter what their ability to pay is. And so with that, we aren't a for-profit system. We do have some limitations around budgeting. We have limitations around, capacities, I want to say how many people we can actually serve, but there is an upper limit to how many people we can serve without staying within our budgetary means. And so, with that being said, we do try to do the most we can for the most people in the most cost efficient manner. And so, in doing that, one of the goals with the organization is really around, can we provide the basic foundational services that a general hospital needs to provide for a community, for a safety net group of patients? We want to be able to provide those things. And some of those things, while they are general, they are still specialties, they are still expensive. They do require a lot of additional resources, whether that's, orthopedics and they need special machines in the OR, whether that's cardiology, to be able to transition those patients to different levels of care, you do have to have those abilities for those service lines to either provide that service or a resource externally to do that. And so, what we try to do is we really try to build the foundation of those service lines so that we can keep as many people within our system that we can. Obviously, we are small, we are independent. We can't do everything for everybody all the time. And that's where our community partners really come into play with us. We are working really, really hard on community partnerships. How do we work with our other hospital systems for if it's a service line that we maybe don't offer, or those patients do need a higher level of care for a service that we don't have the capacity to have? How do we establish those relationships so our patients don't feel that transfer of care, right? We
Oh,
want to have those patients back, but we also want them to go to a place they feel welcome, they feel just as comfortable going there as they do here, and also knowing that they come back. There are some that we can't take back, but we try in the grand scheme of things to bring everything back. And so as far as like when we look at strategic priorities for our hospital, it's number one, having a full, robust foundational service line, having those really core basic service line, making sure there's staff with the appropriately trained clinicians who want to be there, who want to be in your system, who want to treat our patients with along with all the socioeconomic issues that may come. And then we also want to make sure that we are developing those partnerships so there's a easily easy transfer of care, there's an easy conversation. We're not having to go through multiple channels around how we get somebody somewhere, and making sure that we have those resources and linkages set up for our providers so their work is easier.
yeah, you all are obviously listening to you. You're putting the clinicians and the providers first. And as you think through kind of a clinician first approach to all that you're doing to improve patient flow, access, ideally without adding burden to the clinicians. What's working? Can you give us an example of some things you've maybe put in place that allows that to happen?
Yeah. So, I think where we start with that is you have to talk to the clinicians, right? You can't assume what they need. I'm very blessed because I still work very routinely. I work clinically. I know a lot of the challenges, but I don't assume that I know them just from my standpoint. I spent a lot of time with my clinicians in our organization. What do you need? What are the challenges? How can we make this better? And listening to them, because where they're getting their information from is either from each other or from their patients. And it's their patients that are showing up saying, you know what, I couldn't get through your phone line, or I couldn't get this refilled, or I needed this study and this is what happened. And so when they come back to tell you that, you've got to be able to kind of prioritize and listen and say, okay, I'm hearing this 4 or 5 times. What's the challenge? And so there's been a number of different things that we are currently still working through, things that have recently been identified. We did a big EMR switch almost exactly a year ago now, and that was very the clinicians were a big part of that. But what I will say is that we have brought on a whole lot of new clinicians during that time. And so some of them weren't part of that. Our EMR was a huge obstacle to us being able to really navigate between our different places of care for our patients. We had our clinics on one, our hospital on another. Things weren't talking to each other. And so, with any EMR implementation, there's a lot of things that have to happen. And we are still working through, getting some of the information out of it, getting some of the metrics. But what I have heard consistently, and just from a direct patient care perspective, the workflow of the clinician is better. They're able to get their notes done easier. We can send notes to other places. They can now read through and figure out what was actually happening. We can put in orders and have an appointment made before the patient leaves. And so that has worked well. But with that, there have been some challenges around how do we get something ordered, or how does this translate over to imaging. So we're still working through those, but I think, we routinely sit down and say, how can we make this better? We have a great IT department they work hand in hand with our providers. We've developed, workflow efficiencies with order sets specific to the service line, specific to the unit. We've had that ability to do some of those things where it just really helps our providers in treating their patients so they can spend more time with their patients.
So I think what I heard from you was you've got one EHR connecting clinics, emergency department, and the hospital. Is that correct?
That's correct. Mhm.
I know
So
our
it's all
listeners would
everything's
love
on the
to
same
know.
system.
Yeah, which EHR did you all go with?
So now it's Oracle. It was Cerner when we got it. So
Okay.
yeah, Cerner Community Works.
Okay. Terrific. And the world's changing in terms of electronic health record companies. So that's helpful to know. In terms of Nashville General, you have a strong focus on serving the vulnerable population. And that's a unique aspect and blessing coming through
Yep.
Nashville General. What does equitable care mean in practice at your hospital? Like, it's one thing you've got an EHR, you're connecting everybody, you're doing these initiatives like a lot of hospitals, but you all uniquely kind of serve this population. And can you share an example of maybe in a program or an initiative that made a difference
Mhm.
in kind of providing that equitable care?
Sure, I'll be glad to. So, equitable care in our space means that everybody has access to the resource in which they need, however they need care. And that's different for everybody. We have people that come from all different socioeconomic groups. We have all different levels of education, culturally, language. There are people that have what we assume to be no obstacles, and people that have obstacles as simple as needing shoes, clothes, and food. And so we really try to meet our patients where they are. We have two satellite locations and then obviously our main hospital. We do try to keep everything in terms of people that have limited resources in terms of transportation and funding. We try to keep them at Maine so that they aren't having to come back and forth. At our main hospital, we have a couple different things that we do to support patients that can't get around easily. Obviously, we have a lot of patients that utilize our local bus. We have two bus stops right in front of the hospital. We had a transportation van donated by some very generous donors called our Chad van. It was originally set up to get our oncology patients, bring them back and forth to their appointments. Turns out a lot more people need transportation. And so that van runs continuously, but has really helped in some of our patients and our no-show rates just by getting the people to the appointments. We have a food pharmacy within our hospital. These are people can go shop for their medical condition. They work with dietitians. If they have diabetes, they can shop for diabetic diet. If they're an oncology patient, they can have an oncology prescription diet. We have a pharmacy, an outpatient pharmacy within our hospital that actually we have many number of different programs with that. We're part of Dispensary of Hope, which offers low cost meds to our patients. In addition to just regular medications, we also have some generous donor money that's been kind of donated to the hospital through the foundation that helps with some copays. Obviously, we have some patients that they've been inpatient, can't get to the pharmacy. Upon discharge, we do a meds to beds program where anything they're discharged with is brought up to their bedside. They don't even have to go to the pharmacy. In terms of like our more chronic patients, some people that either are constant no-shows or if they're kind of repeat visitors for a number of different reasons, whether they're unable to get their meds, unable to get to their appointment, they show up in the ER multiple times. We have a community care team. This is a multidisciplinary team, case managers, social workers, nurse practitioner that routinely really keep these people in what is essentially almost care management. They're called weekly, followed up. Do you have your medicine? Do you know how to take it? Education. And that has worked out very well. It's provided a lot of resources. It's a nice connection between some of our patients who have challenges around their insurance plans or case managers with their insurance. And so we've done a lot of those things. We have our charity care program for Davidson County residents that qualify that meet certain income levels. And so we do a lot of different things across the board. So it's really not one specific thing. And we have a lot of really engaged employees that are externally connected within the community with some of our very big sponsors in terms of, whether it's a food drive or a clothing drive. We keep what we call a clothing closet just for when it's cold and we have people that need jackets and socks and things like that. And so our community supports us in doing that. And it's been great for our staff because people come and they know that, yes, I have a medical condition. They're going to take care of that, but they're going to make sure that I don't walk out in 30 degrees without a pair of socks on or a hat. And our patients are grateful for that. And they're so thankful that we are able to kind of meet almost all of their needs at times.
Dan, listening to you, I'm struck because hospitals are designed to take care of sick patients, get them out, and we get paid that way. But in listening to you all, Nashville General is really managing the whole care process, the whole person, whether it's from food to clothing and so on and so forth. Any new payment structures on the horizon that you're aware of for Nashville General or any hospitals, given
Um,
what you all do for your patients?
One would hope, not that I'm aware of. We have not ever done it for payment, and that I don't want to sound, like I'm blowing that off, but I think, you know, there people, whether they have everything they need, don't have everything they need. People want to be heard, understood, and really want to also know that somebody is there to help them. That's important for all of us. And I think you want that even more when you're sick and you're ill if you have a chronic condition. And so
100%.
for us, it's just what we do. We're very, I'd say we're maybe a little picky about who we choose to work with us, but we want to make sure everybody's a good fit.
Yeah.
We have a lot of different things that we do, and it takes a little bit extra at times. And it doesn't take anything away from anybody else in this town because I think every healthcare provider does a wonderful job of treating their patients. We just have a much larger group, which with some very different needs, and we want
I think
those people where they're at.
you're speaking to anybody who's listening to the Better Care podcast that's going to relate, because I think we wouldn't be in the industry if we didn't want to help take care of patients and get them back on their feet. And I think you're speaking to kind of a challenge at the heart of all of healthcare, right? Like we're there to help and we have patients that we have to take care of. We can't just kick them out, and you're building programs, but the reimbursement alignment is something the whole industry is struggling with. So we're not going to solve it today, but I do want to point that out. DeAnn, what's one thing you wish more CEOs or executive teams of hospitals understood about chief medical officers and their need to be successful in your role or in a safety net hospital role or just kind of in general? I'm curious what you would want to say to the rest of the C-suite. Help make your continued success continue.
I think, the chief medical officer role is different everywhere you go. And I think it depends on your structure, it depends on your system. In some, it's very layered. You have a lot of resources, you have a lot of support. It really just depends. But I think at the end of the day is from a clinician standpoint, your clinicians are looking to your CMO for the clinical support that they need in doing their job appropriately. And once again, I think the way in which you are able to do that and you can navigate both sides of it because you still are you're still part of the administrative leadership team. How you do that, you got to spend time, you got to talk to them, you got to listen. I always tell everybody, listen first, speak less, say the least amount of words, you'll come out with the most information. Sometimes I'm tasked with absolutely solving the problem in the moment, but a lot of times, if I listen quietly, what I become is a mediator in solving and becoming a solution for some of those problems for people. And it's really providing a forum, a space, and an ear to really understand what the challenges are and see. I think one of the big parts of what I do is seeing it from a higher level, but also a whole hospital perspective. How does it affect everybody? How does this downstream affect everybody, not just my department or my unit? So I think, there's so many pieces that go into this, but what I would say from, the administrative teams is, be flexible with your CMO, be patient. Um, and I think the CMO has to do that as well. It's understanding a lot of different pieces. You really are kind of the middle of the wheel that has branches into everything that goes on in the hospital. And you have to be a partner with everybody because that's the only way you're going to support your clinicians and your leadership team. And at the end of the day, truly support your patients.
That's wise advice any leader can take, not just chief
Mhm.
medical officers. So thank you. When you think about 2026, what are one or two top priorities that you'll be focused on at Nashville General that maybe we can all hear a little bit about and ensuring kind of the clinical teams have what they need to be successful?
Yeah, so I think we continue to build on our foundation. We are really at this point, we recently re-signed a provider services agreement with Meharry and working in conjunction to build up some of those service lines jointly with Meharry, making sure that our patient base is big enough so their residents and students can not have to travel outside of the Nashville area in order to get their patient experience. So that's one, but also continuing to build on these community partnerships in terms of how can we really align some of our resources. But also, for anybody that's been in the Nashville area for any number of times, is rewriting a lot of our history of what the external perception is of Nashville General. I think we've been we've had multiple iterations of what we historically have been, what people's perception is, who we treat, what we do, who we hire. And the only way we're gonna move forward and beyond that and really have people understand what we do is you got to be in our doors. We've got to be out forward facing with you each and every day. This is what we have, this is what we do, here's our providers. And I think really working hard this year to change a lot of that historical perception of things that have just followed us through the years. Our team's working really hard to do that. We've made a lot of forward progression, had a lot of momentum in the last 6 to 8 months, which has been really, really refreshing. I've been at Nashville General almost 18 years at this point, and the level of commitment from our team, our board has just been outstanding. And so I'm excited about the future and the next year and what comes and what we can do to better serve Nashville and the citizens in Nashville.
Yeah, maybe two more questions that come to
Sure.
mind. One, we often have a lot of emerging physician leaders who listen in on the podcast. What one or two nuggets, if there's some up and coming aspiring physician leaders that you might share with them that were helpful to you, that maybe someone shared that kind of helped you move into that leadership role? I know some clinicians want to avoid that; others are drawn to it, and maybe what helped along the way.
Um, I think keeping an open mind, you really do. We all set out amongst a path. I think when you decide you want to go down this role of being in a position, it's a very calculated path. And, you know, sometimes we don't see kind of the forks in the road. And sometimes those forks in a road can be open brand new doors. So what I say to that is if you have the capacity and you have the ability and there's any interest, say yes. Just open your eyes to all the opportunities that can be there and be willing to be continually educated because this is a constant education. You can never know all the ins and outs of no matter how long you do it. Every single day is a new day for me. Every single day I learn something. I think that's one of the things I actually love about this role is that there's always something that comes across your plate. And you're like, well, maybe I need to go read a little bit more, or this is something new coming down the pipeline. So you're constantly being challenged. And you can't be afraid of that. You just have to say, okay, this is where we're at. Let's learn together and move forward. And so I think that's probably the biggest thing is really just keeping an open mind and being a constant learner, being willing to say yes to things. Yes, it may be more work, but how does it benefit your patients at the end of the day? How does it benefit your organization? And part of leadership too is just you sacrifice a lot, thinking about yourself last, you do the work and you do the good, all the rest of it will come.
That's very well articulated for someone who wears three hats and is not afraid of the work. So thank you, Dan. With your experience and kind of maybe looking backwards a little bit, if you could wave a magic wand and kind of fix something in healthcare, what, and especially with maybe some things you've seen that just keep coming back and keep recurring, what would you wave a magic wand and kind of recommend that we either change or do differently?
I think we just have to make it less complicated. It's too complicated for the patients. It's too complicated for the patients. It's too complicated for the providers. That's a big lift. And you got to have a lot of willing parties. But I think we got to start somewhere. And that's what we do try to do for our patients. Let us help you navigate some of this. You've got people that have one, two, three different insurance, a prescription card. Maybe they bought an insurance plan because somebody told them they needed insurance and it was the cheapest thing in the world because they didn't have it, but they didn't tell them what it did and didn't cover, or they didn't understand that. We've got to do a better job. One of the hard things I see a lot is a lot of the patients who have aged in the Medicare who maybe had insurance covered by their employer for their entire life. And you have to think about it. Maybe they choose between one or two plans or didn't have to choose at all. And they end up, now in Medicare and they might need gap coverage and they might need Part D and they don't know why they're paying three different things and which one covers. And it's too hard. It's too hard. And that's not even adding on top, prior authorizations and formulary changes. And I think there's a huge opportunity to make this simpler for the patients. It's really hard for them. And we're not really winning any battles by making it harder for them each and every day. So that's what I would wave my magic wand. I know it's a big wish, but you know, try and do our little part to make it a little bit easier for the patient.
Well, a great man once told me that great leaders make the complex simple. And I think the way you just articulated that is can go in so many directions, but for physicians, for healthcare and hospital leaders, for entrepreneurs, the more we can simplify things. I know you and I've talked, I've been a patient this past year. And if it could have been simpler, like it would have made the whole experience better. And I'm in the industry and it's still complex.
Yeah.
And so thank you for that. That is 100% spot on. And if we can all play a part in making things simpler for the patient and the providers, the healthcare world would be a better place. And
Absolutely.
and DM, the healthcare world is a better place because of you. We're so grateful for you and all that you do. You do make care better, and we can't thank you enough for being a part of the Better Care platform. And you're what we're all about. And so thank you and keep doing all the fantastic things you're doing. We really appreciate it.
Thank you, Bo. Thank you to you and your team always for the support through the years. I always know you're right there on speed dial if we need you. So always appreciative. And thank you for the time today. It's been a great little chat. Lots to come and excited about what we've got coming down the pipeline in the next year or so.
Absolutely.